Hi everyone. We're going to go ahead and get started with today's event. I'm Catherine Harrison. I'm a senior manager here at the HPC on the Accountable Care team. And on behalf of the HPC team, I'd like to welcome you to this knowledge sharing session on pharmacologic assisted SUD treatment in primary care. For those of you that are familiar with the HPC's work, you may know that behavioral health integration is a key focus area for our research and care delivery transformation work. And one of the ways that we endeavor to support access to and integration of behavioral health care is through our PCMH Prime certification program, which recognizes primary care practices that demonstrate capabilities in behavioral health integration. This includes the ability to offer pharmacologic assisted SUD treatment, or as it's still more commonly known, MAT. Now, the need for improved access to MAT is really abundantly clear, both to provide actual improved access to care and to help reduce the stigma of addiction that can deter patients from seeking treatment. The epidemic of opioid use disorder has been well documented, and its effects on our communities are widespread. However, despite strong evidence for its effectiveness, recent analyses show that access to pharmacologic treatment in Massachusetts is limited, particularly outside the eastern part of the state. So it's worth asking, what are the successful strategies for overcoming barriers to the delivery of MAT? And what lessons can be shared by those who have achieved this capability in the primary care setting? So those are the questions that we hope can be addressed through this knowledge sharing session today. We know that there are no more powerful teachers than those who have been through the learning experience themselves. So we're really excited and honored to be joined by our panelists today to hear more about their experiences introducing MAT into their practices. This event is being delivered under the guise of our technical assistance program that the HPC offers to primary care practices participating in PCMH Prime. And we've partnered with a team of practice transformation experts at Health Management Associates to administer that TA. And one member of the HMA team is going to be our moderator today. She is Dr. Suzanne Mitchell, a family medicine and palliative care physician on staff at Boston Medical Center. Dr. Mitchell also works as a physician consultant, addressing challenges with health service delivery, behavioral health integration, and care transitions. And her areas of expertise include the intersection of addiction and advanced serious illness. I also want to just briefly introduce each of our panelists, who will talk a little bit more about who they are and what they do in a moment. But first, I'd like to introduce Dr. Kaimi Mahania, who serves as the CMO of Lynn Community Health Center. We're also joined by Dr. Jessica Gray, who's an addiction medicine fellow at Boston Medical Center, Dr. Ellie Grossman, a general internist and the primary care lead for behavioral health integration at Cambridge Health Alliance, and Dr. Marcelo Campos, a family doctor working at Harvard Vanguard Medical Associates. So in a moment, I'll turn it over to Dr. Mitchell and the panelists. Before I do, I want to thank those who are in the room joining us today for this event. I also want to welcome and thank those who are participating via our live stream. It's very exciting. And if any of you live stream viewers have a question or you want to get involved in the conversation, you can email us during this event at hpc-certification@state.ma.us. I'll be monitoring that mailbox and we'll be happy to share any incoming questions with Dr. Mitchell and our panelists. So again, that email address for the live stream viewers, hpc-certification@state.ma.us. I think with that, I'm going to step out of the spotlight here and turn it over to our expert guests to have the floor. We're really looking forward to a rich and informative dialogue, so thank you very much.
Thank you. Good afternoon and welcome everybody. We want to encourage a dialogue and a discussion format today, so please raise your hands or feel free to speak up and ask questions. We hope that you'll, if you want to ask a question and you're not seated in front of a microphone, that you'll step up to the table and access one of these microphones. Just make sure the little green light is on so that we can capture your question and everybody can hear who's listening through the live streaming. We do have some questions prepared, but if you have questions you want to ask, this is meant to be really practical and applied. We thought we would get started by letting our panelists each give a little bit of background about themselves and their experience delivering mat therapy in their primary care settings, and we're really trying to focus on the delivery of treatment in primary care, recognizing that there are other ways for people to access treatment for substance use disorders. So without any further ado or delay, I'm going to pass the baton to Kiame and ask you to please begin our discussion. Can you tell us a little bit about your experience getting started with mat therapy?
I was hoping we'd start at the end.
Oh, sure.
That's okay. I'm Kiame Mahania, so thanks for the opportunity to be here, even though Suzanne had to strong arm me somewhat. And so I've been involved with MAT, maybe since Marcelo asked me this question recently. I think it was 2006 that Marcelo and I started working together on it. So it's from 2005 to 2006. So I've had the advantage of working at 3 different health centers on MATs. One MAT program, we started bare bones. We had no support. We had no behavioral health. That was when we started in Lawrence. And then a few years later, I got to start a new program at North Shore Community Health Center, which is based in Salem, Gloucester, and Peabody. That was a different experience because we actually had one behavioral health FTE to help us with what turned out to be around 250 patients. And then now I'm at Lynn, which is, when I joined, it was already a mature program, and I've sort of just been helping develop it further. It's a fairly large program with around 500 patients and a full complement of therapists and psychiatrists throughout. I sort of stumbled into MAT by accident. I was working in Lawrence at the time, and in terms of, I was thinking, wow, why do most people end up in prison from Lawrence? And it turns out the main reason people ended up in prison was drug offenses or robbery because of drug use or violence because of drug use. And it turns out at that point there was only one methadone clinic in all the city. So it was a pretty easy thing to think, oh, that we should start and do something. We were lucky enough to have a residency, so I convinced the residency that if they were into social justice, they had to require training. And so they signed a petition to the residency director, who then said, okay, all faculty is obligated to become certified. So that's how we got started in Lawrence.
Ellie Rosman, currently at Cambridge Health Alliance. I've actually worked in 2 different settings delivering this type of treatment in primary care, and also like to reflect a moment on both of them. When I started this work, I was in New York City at a safety net public hospital system where we built buprenorphine services within a primary care clinic at that institution. And there it was basically a group of doctors who said, hey, this is important to our patients. Buprenorphine at that time had been on the market a few years, but not very long. And we developed a group of providers that co-managed the patients basically. For a lot of schedule reasons, we cohorted the patients all into one half day. And it was kind of us and MA. Yes, we happened to have a methadone program in another wing of the building so that a patient could enter the same front door and go to methadone if they needed to. But we certainly didn't have any behavioral health support within our clinic. We sort of just did it with an MA and a bunch of docs. And built it over a number of years there. And so that's one story. The other story is my experience at Cambridge Health Alliance these last 2 years, where the practice I joined did not have another provider doing buprenorphine in the practice at the time. It was something I came in saying, hey, I want to keep doing this. And they said, hey, yes, our patients need it. We're glad to have you. But I kind of took my New York model and brought it into a new clinic. So again, I sort of kept this model of docs seeing patients with an MA doing urine, and that was the way we did it. That said, Cambridge Health Alliance does have a relatively robust integrated behavioral health program. So as I got my legs under me, I was able to get our integrated therapist involved, and so now she does a group on the same half day when I see many of my patients, and we work together relatively smoothly. And we now have trainees who work with me. And then there are a variety of other models even within Cambridge Health Alliance. Some do group visits as a shared medical appointment. I'm happy to address thoughts, questions about that later.
All right, hi, I'm Jessica Gray. Thank you for having me also. I guess I'm here from a little bit of a different perspective. I trained in family medicine and worked in primary care in a federally qualified health center for a year in Dorchester after training. And at that point, I had limited training on MAT and felt pretty unprepared, but realized that it was something that I was very, very interested in. So I ended up going back and doing a fellowship, which I'm in right now. I finished up in December, an addiction fellowship at Boston Medical Center. So my experience with buprenorphine as a primary care physician and as addiction fellow kind of spans a bunch of different organizations. So I saw how it was done at the primary care center clinic in Dorchester, which was a 3 or 4 doc and nurse model, the OBAT model for BMC. And now I spend most of my time in Boston Medical Center's OBAT, office-based addiction treatment, kind of program, which is pretty enormous. Again, 500 patients, 6 or 7 nurses. I think we have 17 or 18 waivered physicians. And I'm happy to talk more about that, and I think it's a great resource for people who are starting out. We have another model within BMC's campus, which is the group visit model, which I think is another interesting thing to potentially explore in terms of your visits. So that's where I am, and I'm doing full spectrum addiction at this point, so can you talk more about that as well?
Hi, my name is Marcelo Campos, and I currently work down the street here, in New York Street, Avant-Garde. And my experience was exactly the same as Kiani's experience. So we started together prescribing buprenorphine to patients in Lawrence. I was basically obligated to do the waiver training, like with many other faculty members. And because the residents want to learn on how to do the treatment for opioid addiction. But it was nice because they created a nice model of stabilizing patients on buprenorphine. They would shift the patients to different PCPs once the patients were somewhat stable in the maintenance phase. And we always had questions to ask. Kiani specifically about how to go through problems that the patients had. So after leaving Lawrence, I came to another location, then to Avant-Garde. And when I arrived here, there was no established program, and still there isn't a very established program. It's basically different providers, clinicians, either in primary care or in the behavioral health department, because they feel the need to learn about this. So people on their own, they started to do the training, and they started prescribing buprenorphine. And because, interesting enough, like 6 months after I started Avant-Garde, my patient, I had one patient of mine that I did not know that she had a problem with addiction, and was my first patient who died. She was 36 years old, and that immediately pushed me to go ahead and start the program faster. And so I had the support from leadership, but it's something so unusual to do typically that I had to I had to do all on my own, like to try to figure it out how to manage this. And because I had an experience with group settings as well. I had the idea to also create a group, and so I started to the whole process initially recruiting patients on my own face-to-face visits, and eventually when I reached about 6 patients, I decided to create the group. So the group has been running for the past 2 years now. Very successful.
I kind of liked the fact that you brought up a patient experience, and I wonder if there are other patient experiences that other panelists could talk about that were, kind of transformative in helping you become committed to this area of practice. Do you have other patient stories that you could share?
Sure.
Yeah.
Actually, for me, it was my patients with alcohol use disorder that really pushed me into getting more training, because I just really, enjoyed the honesty of the conversations that we had when I got patients to open up, and felt so inadequately trained on how to actually take care of them. And so that actually initiated my interest in getting more training, along with the opioid epidemic, of course. But so those were some of my patients. And I think that we all have these moments of people who we didn't get to in time. I think of one patient I found outside of BMC, after being in the emergency room and just over sedated and sitting up there with her discharge paperwork. So even at kind of the most robust places, people are falling through the cracks. And so, yeah, I think those are helpful for me.
For me, what keeps me, what I guess got me in this, but really keeps me in it, is the day-to-day life stories that I get to share with patients, because as patients are entering treatment, visit frequency is pretty high. I'm typically seeing them once a week, and the visits might be relatively short, but that's different than every other chronic disease I manage in primary care. And so bit by bit, you hear all these details of their everyday lives and their child care needs or their elder care needs, or hey, my family thought I was looking pretty good when we all went out to dinner this weekend. And you get to feel these wins with patients. Clearly there is the worry, and the worry about patients is different these days with what is on the street these days. If a patient misses an appointment, I worry about them in a way I did not worry about them 5 years ago. Maybe I should have been worrying about them more 5 years ago, but really and truly things are, what's out there now is scary. But for me, what kind of keeps me in this is actually the positive, is the, hey, I am thinking about going on a job interview, or I actually went to a meeting, or I got to go visit my son. These little things that are short-term wins in addiction treatment that I actually, for me as a primary care doc, you don't get that with diabetes. No one comes up to me and says, hey doc, I'm really glad you helped me prevent my heart attack by 10 years. Like, that's a good thing, I'm not belittling it, but it doesn't actually make me happy on a daily basis. Whereas this care, it's actually really rewarding. It is quite frustrating, and there are patients that slip through the cracks and patients you worry about. But the wins, even if they feel kind of small when I'm sitting here telling you, they're very real for individual patients and their lives and their families, and I must say this work is so rewarding.
I think one thing I want to emphasize is, number one, I have tons of patient stories. One of sort of my favorite that sort of represents the sort of dilemma of it is that, once your patient gets stable, you offer them to wean, but you make sure that they know they get to decide if you want to wean or not, because the numbers are terrible if you force people to wean. And there's this one patient that I had, he was in his 60s, and I'd had him for 2 or 3 years. And I kept asking him, because he was stable, doing well, and he said, Dr. Mahanian, I've already written it in my will. When I die, I want you to get a Suboxone pill and place it in my hands as you're closing the casket. Right? I was sort of like, I was thinking, well, I guess he's never coming off. It was sort of illustration of just all the different sort of forces that can come into play. But one thing that I think you've heard, and I think that surprises people, prescribing buprenorphine is an intensely spiritual experience. It's the most spiritual part of my practice because patients are talking. When you think of what addiction represents and how much pleasure it represents in people's brains, for you to give that up is an amazing feat, right? And the reasons people give up that amount of pleasure is sort of fascinating. And I really think that having been a physician that prescribes Suboxone for the last 10 or 13 years has actually changed me as a person. Like I feel that I've become a better husband, a better father, a better physician, just a better person in general. Because I just feel that it forces you to confront yourself and what's important to you. If that's important to the patient, what's important to you, and you're forced to share certain bits of you with the patients as you're trying to reach them where they are. And Marcelo's experience is really not that uncommon, where people do it because they're sort of forced by the system to become certified, and then they fall in love with the process. I can't tell you how many of my physicians and now NPs and PAs are resistant to the concept of becoming certified. And then they started, and I actually have a few of my colleagues that were incredibly resistant to me when I started in sales who are now running their own OBOT programs. Like I really feel it is a life-changing therapy, but also for those of us who are prescribing. Another thing to reinforce what was said is that in primary care, we rarely get to know the names of the people whose lives we're saving, right? We sort of think, okay, we got 500 more people controlled on blood pressure. I've prevented 3 strokes. I've prevented 5 heart attacks. Or I immunized 1,000 kids against the flu. I've prevented 3 pneumonia admissions, right? But with Suboxone, you see the faces and the names of the people whose lives you've saved. I mean, it's a very unusual thing for us in primary care. And so, of course, because there's a much higher mortality rate, you have to have a good support program for your staff because people will die in your practice. But the wins are simply incredible. The amount of pain that people live with when they're using substances, and the pain that their families feel, and that you're able to help in such a way. I mean, the success rate is around 60% sobriety at 1 year for most programs coming in and out. And that's just an amazing, when you think of if every person is intimately tied to 10 or 20 people, right? So if you have 100 people in your program, you know that's 60 people. So you multiply that by 10 or 200, so you're right for 20, so you get 1,000 people whose lives have become incredibly improved because of the efforts that you're doing. That's sort of it's just an amazing, I really find the whole experience of prescribing an amazing experience that I'm not able to reproduce anywhere else in my primary care experience.
It's a multiplier effect. My personal experience was sadder and not as successful, but it really opened my eyes to the need of treatment, because I was, as a palliative care physician, I get called always to the most sad experiences, and it was a very young guy, 30 years old, who was dying of heart failure because his heart valves were infected, and they asked me to go and explain to him what was going to happen to him, and that he was dying as a result of having untreatable heart failure because of that. And when I looked back at how his care had gone, he really, even though he had had a valve replacement, he wasn't able to access the robust outpatient treatment that he needed to manage his addiction. He was discharged from the hospital and without a plan. And I feel like that, that was just naive of us to think that a new heart valve would change somebody's life that quickly. And I remember having to talk to his mother. I mean, you talk about the family members that are kind of collateral sufferers because of this, and yet it's very treatable. So for me, it was really proof that there was a need to expand access to treatment. So I think with that, it would be great if we could talk a little bit about access to treatment and the different models. So far, I heard you talk about shared visits, group visits, and OBOT, and maybe not everybody is familiar with those models. So would somebody like to talk about the the shared visit model first. I think, Marcella, you said you were implementing that group visit.
Yeah, so what I usually do is have the setup where patients get referred to me from different clinics. There is a central person in our mothership, Kenmore. So if a patient needs to get treatment for opioid use disorder, this person can be in contact with this intake process. Where several questions are asked, and this is done over the phone. It's just basically, a history that is taken for a few minutes, and she immediately, sends me an email about those patients that want to come in, and every single patient is told about the group visits, so they have to come to the group visits. Part of the treatment process. It is not only the medication, but the support from counseling and the group support. So there is a time, it's on Thursdays, from 9 to 10:30. You have to come in in order for you to be accepted in the group in the process. And so if the patient cannot do it, they can get shifted to other places. There are other physicians that would be able to do that in different times. So I received the email, and immediately, because those patients, when they call to asking for help, I have to create access, the same day or the next day, right? So, my staff already knows, that they deserve a special treatment, and so they immediately we find a time for those patients to come in less than 24 hours. So I start the process, and started with induction. A lot of those patients have already tried Suboxone on the street. It's very, very common for patients to try before, so they know what to expect. In the past, I was putting more control about taking those medications and supervising in the very beginning. But once I felt more comfortable with those patients, if they know what they are doing, sometimes I just send them home with the medication and ask them to come back a few days later to see and titrate the medication accordingly. This usually happens for about a month, 6 weeks, and in the meantime, I already sent the patient to have a face-to-face encounter with the therapist. And eventually, if some of those patients, they cannot follow, so they go somewhere else, or they give up. But most of the patients stick around, and they eventually go to the groups where we have groups on a weekly basis, and the shared medical appointment that I am present happens every 4 weeks. So on a weekly basis, they have the encounter set up with the counselor who has training with substance. I was lucky to be in a place that I have someone that has been working with substance use for 30 plus years, and so they meet with the counselor on a weekly basis and with me every 4 weeks.
So I just wanted to make sure I understood. So there's a group visit that's every week, and then they also have an additional face-to-face individually with the counselor, and then every
In the very beginning, they have the first couple of visits face-to-face with the counselor, and once the counselor and I decide that the patient is fit to go to the group, this may happen, in the first week. But sometimes it takes a couple of weeks until the patient is completely stable to go to the group. It's a case to case that we decide. Sometimes we say, I don't think this patient is going to do well in a group setting. It happens. Very sporadically. It's not very common. But sometimes patients are not. They prefer. I try to tell patients that they have to go to the group. It's obligated, but sometimes we have to do in a in a private setting, because some of the patients have problems with anxiety, and they don't like to share. It's not for every single person. So
Are they resistant to the group?
some are, but once they get to the group, it's a transformative thing, and they create those relationships, and so that's fascinating. The group support. It's beautiful to see once the group takes shape of this bounds of support systems that they have once patients go into relapse, and how much support there is. If someone doesn't show up, they are Facebook and say, "What's going on? Why are you not here?" And so it's transformative.
Are there questions about implementation of group visits here? People implementing group visits? Yeah.
What is the credential of the counselor?
It's a social worker, and he has training in substance use.
And how are you compensated for groups?
So for the group sessions for the counselor is a regular visit. For them, I do not know how is the billing process. For me, it's just a regular medical appointment that I did level 2 to 3 every 4 weeks.
Weekly visits are compensated with a counselor?
I believe
Switch these out.
they are. Yeah, I believe they are.
We in Cambridge Health Alliance, we have a variety of types of groups that happen around substance use. At my site, the group is run by our integrated therapist, who's a PsyD, a psychologist by training, and she bills it as a group therapy visit. Patients are often also seen by me on that day, billed separately, etc. There's no physician or prescriber in her group. So that's another way to do it. Some of our sites also do a group visit that's billed by the MD as a shared medical appointment. The group itself is facilitated partly by the MD and partly by an addictions trained nurse case manager. And one of our sites actually builds trainees into it so that they, so these are residents of medical trainees. So actually, at a certain point in their training, the residents are actually leading the group. So hence, they're actually learning group facilitation skills as well as the addictions. And we bill based on who's leading the group.
So similarly, in where I am, there's one group led by a psychiatrist, and he does it all by himself, and bills for a shared medical visit for however 6 to 8 patients he sees. And there's an MA for all of our groups. There's a medical assistant who gets the urine, beforehand, and kind of helps facilitate that. And then for the family doc who does it, she actually co-leads with a social worker who knows them very well and is kind of tracking them. And she also builds for the medical visit. So that's how it works. And in terms of stability, so initially everyone must come weekly, and that's when they get their script and they show up and then that keeps everyone going. But once people get more stable, there's generally like a little flexibility, and so in that same group, we have people who are on weekly scripts who are coming weekly, and then we have bi-weekly and monthly. So those are all in the same group and all supporting each other. So it's actually really nice to mix people who are kind of just starting their journey and with others who have some months to years under their belt and can offer a lot of guidance and support.
Other questions? Okay, great. Could you just, for the sake of clarity, maybe Jessica, distinguish OBOT or explain OBOT?
So it used to be called OBOT, office-based opioid treatment, which was started by Colleen LaBelle and Boston Medical Center. And they've now changed their name to OBAT, office-based addiction treatment, which incorporates alcohol treatment as well. So that is, the hub is at Boston Medical Center, but many of the health centers around the state have implemented that model, which is a really nurse-driven model. And I'm happy if anyone wants me to put them in contact with you for kind of their policies and procedures in their manual, which kind of walks you through every step of the process. You don't need to reinvent the wheel. And then they're there for really, central support to get you started. They train the nurses with you. They have regular follow-ups with nursing. They're there for questions. But the model is this nurse-driven one where you have an intake with a physician who assesses for the use disorder, who assesses the labs and makes sure that the patient is eligible and kind of how to start. And then really the nurses are running the ship, and they're helping with inductions if they need to, with titrations, with appointment follow-up, with coaching weekly, with supports, and then you see the doctor at least every 4 months, but more often if the patient's unstable.
Yes, yes. Any questions about that nurse-driven model? No? All right. What questions do you have?
I have a question. So how does it work for the prescription piece, with the nurses, running the show? Who is prescribing?
So usually if you, as a prescriber, you have your set of patients in general who you sign for. So they kind of, if you're not there weekly, they find you and we make a plan to meet. And we're always communicating via the electronic medical record or by phone if there's any concerns. So I'm there every week, so I'm signing scripts every week, and they're kind of prepping them and holding them, and for refills, etc. And if there's someone out or if the prescriber is out, then other colleagues will be backed up.
And actually, Suboxone is a refillable medication. So we actually write all of our prescriptions with 5 refills, and we have an agreement with any of the local pharmacies that a person can only get a refill if they have an embossed letter from one of our nurses, so that the refill just exists at the pharmacy, but the patient doesn't have access to it unless they've had their nurse visit and they have an embossed 3D paper that they have to bring with them to get the refill, so that in case on a vacation or want to bother somebody else, you can just do it through that.
Do you still have your patients going on a monthly basis for urine checks?
So I think we all this gets into sort of like the reason I'm smiling is that as all my colleagues can say, it's a constant battle within your team to make sure everybody stays in the same play area, right? Everybody wants to play outside the sandbox. And so typically what happens, so I'm a proud Colleen LaBelle baby. That's how we started our program in Lawrence. So typically the way it works is you come weekly for 6 weeks, and if you have 6 sober urines in a row, you go to every 2 weeks. You do that 3 times, and if those 3 are sober, you go to every month. So on that, there's pretty much consensus around the state. But that question is, what happens when someone has been at monthly for a year and a half, 2 years? That's where there's divergence, and we can sort of find out what people think. I sort of feel that once someone has been stable for a year, I'm fine with them coming every 60 days. And if they've been stable for 2 or 3 years, I'm fine with them coming every 90. I sort of, they're stable, they have a chronic disease, right? Treat them any differently. But there's a divergence of opinion on there.
I would agree. I mean, I think it's part of, we talked about what are the amazing things about being in this, treating these people, and it's really the success stories, right? It's seeing patients. I have the privilege of seeing patients with my colleagues a lot. So, I have patients who have been stable for 8, 10, 12 years. And this is just a check-in for their blood pressure or for whatever it is. And it's so rewarding, right, to see that this medicine works and works long-term and people have their lives back. And so I think it does create undue burden on people who are working, have families, to, if they're doing that well, to make them come in every month. Because we know how hard it is to get to the doctor, right? So why make it harder for people who are doing great?
So I think people people who are in attendance and listening would be interested in how you get started. Like, what do you have to think about in the planning process? How do you assess the need in your practice? So if you're gonna decide to do this, you know, there may be practices that don't know or aren't aware of how much demand there might be. Or if they were to start a practice, how much demand they might experience when people know that they're offering this kind of treatment. So what are some of the steps you have to think about to plan to get started, you know, about your team, about capacity, about resources, and what's the ramp up time for those who have actually started new programs?
So what do you need? Bare bones. You need at least 2 prescribers. Anybody else feel free to jump in when I say something wrong. As a bare bones, you need 2 prescribers. You need some system for making sure that urine tox screens get collected at visits. So that's presumably via a medical assistant, but it could vary practice to practice. You need some system to make sure that the writing of the prescription is connected to the behavior you want the patient to be doing. So, for example, they don't get, where I've worked, I've set up systems with the MAs that I do paper prescriptions so that they know the MA does not give the paper prescription to the patient until we know we have the urine and a follow-up appointment is booked, for example. There are other patients in whom attending a group therapy visit is mandatory to remain in treatment with me. I don't mandate that for everybody, but for some it's needed. And then I may give the prescription to the therapist. So again, sort of some thinking about how you're gonna just do prescriptions. Is it electronic? Is it paper? There are pros and cons of either. Those are actually really the basics. This is not, this plan is high stakes. We're doing a whole webinar about this, but this is not actually rocket science. I don't mean to belittle any of my colleagues here, but actually, like, we do a lot more complicated things in medical care than do this.
Like what?
So manage somebody's diabetes with insulin, for example, where I want to make sure I'm not dropping their finger stick too low or letting them run too high for too long. And again, we come up with systems to keep an eye on people as best we can. This is another chronic disease, and in terms of delivering the care, I think those are the main ingredients. Again, it's sort of an assessment of physical space. So could you even entertain doing a group visit in your space? Could be that that's just not a reality. Fine. Or maybe it is, and then you need to think about who would run the group and who goes to the group, and is group attendance mandatory or not mandatory for the patients. And then another piece to think about and plan for ahead of time is who's your backup, probably not at your site. Because there will be patients who you meet who, especially in primary care, we think of ourselves as relatively low intensity addiction treatment. Okay, we may or may not have behavioral health services on site. We certainly do not have the day-to-day, eyeball-to-eyeball contact that, say, a methadone program would have. And there are going to be patients who need higher structure than we can typically deliver in primary care. So just thinking about ahead of time, when I have that patient who is not doing well, who may have ancillary drug use going on, who, for whatever reason, is just not able to handle showing up for a visit weekly with a doctor, where am I going to go for help for them? Who is my nearest methadone program? Are there other intensive outpatient programs that can meet more complicated behavioral health needs? And there's some primary care practices that are quite well equipped to deal with these things, but that's something that you can anticipate ahead of time is going to be a need. Those are sort of the biggies.
I would probably add, because there's still a fair amount of stigma, at some point you need leadership buy-in into this. Because they're going to have to support the efforts, you're going to have to deal with anywhere I've been, there's been blowback, right? It's just unavoidable. And my theory is anytime you're doing something meaningful to help people, somebody's going to resist. That's just sort of the rule of human existence. And so you're going to get blowback, and you need leadership to be on board to be able to defend your flank while you're doing this. And then, like was mentioned, BMC is an incredible resource. Like, this is not a knowledge issue. You can download all their policies, all the protocols, and just take off their logo and put yours. You know, like the policies and protocols are super easy. They're all over the place. The federal government produces these tips that are amazing. I mean, I started a program with reading one tip manual. You know, like that they have a manual for that. Like, it's very easy. And I would say, related to what Ellie was saying, you need to decide where your boundaries are. So, for instance, in Lawrence, because we did not have psychiatry backup, we decided, okay, anybody who's on benzodiazepine, we're just not going to take into our program. Like, that's just a marker of something that's too difficult for us. Or anybody who's been admitted for a psychotic break, we're also not going to take, because you make your own rules. Like, how young are you going to go? Are you going to take pregnant patients? You're not going to take pregnant patients. You know, you just have to have some basic understanding within your team of what realm you're playing in.
And the other, in addition to the leadership buy-in, is staff buy-in. So when I joined the practice where I am now in Somerville, I think staff were told, oh yes, there's this new doc joining us who's been doing Suboxone. And clearly there was some mixed feelings about that among the staff. So in my first few months there, we had some all-staff meetings, some smaller groups, some bigger group, but I really kind of laid out, what had been my experiences at previous institution, how I thought the visits would go this time, what likely to be the biggest patient issues, and open it up to questions. And then since then, so some months in, I've kind of taken a little time at a staff meeting and said, hey guys, how's this going? And sort of do some, checking in. Early on I had a patient who was causing a ruckus at the front desk, and I, number one, addressed it with the staff and the patient, but also let all the staff know that I had addressed it with the patient. So everybody I was quite careful about making everybody feel that we're all in this together and their concerns are heard.
So you had mentioned the question of where do you find these patients? And I would say you already have them, right? And a lot of them aren't talking to you. And so it's the questions you ask, right? It's the screening, it's figuring out, there are some very easy, validated screening tools that you can pull in that don't need to add to your necessarily visit, but can be a part of the medical record or part of a written questionnaire. But if you ask the questions, people will respond. And so I think that's one thing. And the other thing, just to think about starting out, which might sound strange for me, is that start small and pick patients who are not that complicated, right? Choose one or two patients who don't have everything else going on with them to start with, to get your feet wet, right? You don't need to pick the most dire situation. And I think starting small and starting with people who actually are more stable, will make things flow better, and you can kind of figure things out as you go.
About this, because in Lawrence, I have never done an induction, right? So, because there was a whole program set up to do the induction for those patients. And so when I started here at Atrius, I had to learn how to do induction. And I was, sometimes I try to complicate things, and try to see if there is any other way to do. But it's a very standard protocol. And after doing this for 4 to 5 patients, you start to feel comfortable, about what you're doing. And if you look it up, how to do it, it's fairly easy, how to do all of those things. So in the beginning, I was skeptical, but it's really not rocket science. The way that I operate is try to make this it's a chronic disease like any other disease that I see in the clinic, right? So this is my mindset, And I try to do the same thing that buy-in from my staff. You know, I often ask during for the SMA, I actually ask permission for patients, and I tell the medical assistants and the nurses, come down, you know, and experience the SMA for a few minutes for you to see what actually happens. And they understand that, you know, completely, it's a completely different setup that they usually see from other patients, and you know, the reality that they see on a day-to-day, and they understand what is the role, you know, that we play for those patients. So I think that's a nice way to buy in, you know, from you know, people in the pharmacy, you know, from medical assistants, nurses, and other clinicians as well.
Does anyone in the room have concerns about leadership or organizational buy-in or strategies that you're using to get it?
Not within the organization, but how about political leaders in the city or in the community?
So I would say, you know, from my experience in a few different communities, the healthcare system is behind virtually every other segment on this. You know, if you start a program, the police is automatically your best friend. The police chief loves it. It means less overtime for him or her. It means less crime. I mean, it's just that the justice system is way ahead of us on this one. They've started to have drug courts. They're trying to change the name for drug courts now because it's not friendly enough. But they've had drug courts going for 10 years. You know, there's remarkably little resistance from political and other entities when you start doing this. People understand that this is destroying their communities. They want options other than what they have now. They want people to be able to access it everywhere. One of my big pushes now is that we're starting to lessen the stigma, but it's still seen as a poor people problem, right? And so if you look at the community health centers, there's about 50 of us in Massachusetts, and there's 35 of us that provide medication-assisted treatment, and I'm working with a Mass Link program where in the next year, 10 more will be providing, and the year after that, 10 more will be on board. So pretty soon we'll be closer to 50. It's the private world that really needs to step up on this, right? It's where I live in Andover. That's where people really need to step up and sort of really participate on doing this. But you're not going to find resistance from churches or politicians or nonprofits or the police or the courts. They're desperate for us to be doing this work.
So I'm at a community health center, newly at a community health center meeting, and hearing a little bit different of a response from the community. So I'm not sure if they're all equally embracing this.
And Dr. Mahoney and maybe Dr. Gray, I know that especially BMC, as you opened your new addiction center, and Boston Healthcare for the Homeless has a good spot. The neighborhood, probably to your point, that not the churches, not the police, but the neighborhood has been resistant. I know you guys, maybe not you individually, have done a lot of community outreach town meetings trying to help them understand the benefit of this. So maybe you could speak a little bit about that, or you probably could in one too.
Yeah, so yes, there's a lot going on in the South End. There's a lot of great work and there's a lot of visible work, which I think is your point. In terms of office-based primary care addiction treatment, I haven't heard a word, right? People are very supportive, like you said. You know, helping people at their doctor's office, I think in the community has not been an issue. What the community sees are people who may be going to isolated methadone clinics, you know, who may be actively using on the streets, and those people generally aren't in treatment. And so, you know, the BMC, the Health Commission, Healthcare for the Homeless, all these, we're all trying to figure out how to engage people who are at different places in their use and in their recovery, and so I think that's a different set of concerns. I mean, I'm wrong, but my understanding is, you know, that's the visible people that the communities are struggling with, rather than people who are in office-based treatment, because that's the beauty of it, right? It's just another chronic medical condition.
Yeah, one thing is that, so when I have people who resist, I invite them to come to our health center, sit them in the waiting room, and I say, okay, you tell me which of the patients are coming for Suboxone and which are not. And invariably, they take the patients who are, causing issues, and invariably they're not Suboxone, patients on Suboxone. Like, it's just, it's not a, there's always resistance to this idea because we framed it in our mind that it's the other, right? That we have good people who don't do drugs, and then we have the bad people, the untouchables who do drugs. And so when you start this conversation, they hear it as, oh, you want to bring the untouchables into our nice community. And so you have to figure out how you're going to get over that divide, to realize that it's all us, right? We all have family members that are involved with us. We all have friends that are involved with us in our community. And that's sort of the first thing that you do. But my theory is that all resistance is valid, right? You just have to address it. But all resistance, typically, especially in a health center, it comes from a good place. They don't want these patients to die in the streets, right? The resistance is coming from a good place. So you have to figure out, where is that resistance coming from? In Massachusetts, the nice thing is you can go to BMC. So I dragged my nurses to BMC back in 2006 to convince them, and they talk to other nurses who are on the floor. You can go visit health centers and hospitals and primary care offices. Like in Massachusetts, it's a luxury that there's people already doing it.
Well, I think
We have resistance even for the health center, so it's deeper than just the Suboxone.
I think that one of the reasons I was saying, how do you find out if you're a practice, how do you find out how much need you have, right? Is one way to try to, leverage buy-in for, like, look at, this problem that we have that we weren't even aware the magnitude of the problem. So let's say that you're in that kind of a setting, what's the first step you can take? How can you unveil the problem that's in the community? Because I think it's easy for, especially, the non-community health centers to say this isn't a problem for us. It's not here.
I think it would be multifactorial. Number one, Quest does tests for all the work for something like 25 or 30% of all employers in the U.S. Right? 4% of all their tests on a yearly basis come back positive for an illicit substance. These are employed people with benefits, right? So that means that you can just take your practice, take however number of people you have in your practice, figure out what 4% of those are, then divide that by 2. That's the number of illicit opioid users you have in your practice, right? That, whether you want to admit it or not, they're there. And of those, 20% would say, yes, I want treatment if you offer it. So those are pretty big numbers. For us in Lynn, it's very easy, right? We're one of the #1 places in the city for opioid deaths and opioid overdoses. Union Hospital is the #1 hospital in the state in terms of percentage of visits to the ER that are related to a substance use disorder. So in our setting, it's very difficult to be part of the community and say this is not a problem. It's not a problem here.
Yeah, I guess and for anyone who's living in Massachusetts, or some would argue the United States these days, to say, like, this is not my problem, doesn't really feel real. Because, yeah, you may not know it's a problem, but odds are it's there among your patients, among the families and loved ones of your staff. Which is interesting and I guess a little bit flattering, but among my very first patients in Somerville have been family members of staff. Again, our staff live in the neighborhood where our practice is, some live further away. But yes, these diseases are in our communities, period.
And it's not just opioids. I mean, I think that's the other thing that Jessica was saying, like, we don't think necessarily about alcohol abuse or dependence as visibly as opioid, but it's in that same category. And I think we would all acknowledge that every practice has visible problems, people struggling with alcohol dependence. And so trying to find ways to establish the need. Is there also a need to establish a business model when you're thinking about putting resources into the into a new treatment approach? Do we need to have some tools around business models?
Can
Yeah,
I back up and answer the last question though? In terms of if you want real data, so our state is really excellent at digging down deep into data on overdose deaths and, by city, by county, and you can find that, I think SAMHSA, BSAS, and I can help connect you, but, you can drill down to the county-wide neighborhood level and say, this is how many people died in the last year, in the last, 6 months. And I think that can, again, can be very powerful, especially if people are saying it's not in my backyard. So,
yes, so in Lynn, the police geocodes all the overdose calls. And so you can go to a neighborhood and say, this is how many people overdosed in your neighborhood. And I know it's an underestimation because when they go to sort of a nice neighborhood, they don't say it was an overdose and they're afraid of embarrassing people. But yeah. In terms of finance models, this is where it makes a difference whether or not your community health center or private world, the billing is completely different. So the Mass League has actually built a model for health centers to figure out what your billing system will be. But what there is no doubt in the health center world is that this doesn't cost you money. This program, if anything, the 3 programs I've been at make enough revenue that we use the revenue from the program to support our other money-losing operations, right? And then in a capitated setting, so my health center is part of the health center ACO, C3, and our top 10 preventive utilization of our top 10, 6 of the top 7 are related to behavioral health in some way, shape, or form, and alcohol and opioids are first 1 and 2. Right? So in a capitated model, you're not going to be able to survive without providing treatment for these issues. And in a fee-for-service model, if you use the OBOT model that has been made sort of famous by colleagues, you're making money towards your bottom line to support the rest of your operations. And obviously, it depends on your breakdown of insurances and things like that. But in general, this is one of the frustrating things for those of us who are sort of evangelists about this. This is one of the frustrating things, right? There's a problem, there's a solution, there's a knowledge of how to implement that solution. It makes money. So why is there resistance, right? It's sort of like this, it's sort of a weird phenomenon. That if you let it affect you, it makes you frustrated. But stay positive.
So in a nuts and bolts fashion, I don't know, Marcella, your program is relatively new. Like, I mean, how do you accrue patients fast enough, or how quickly do you accrue patients so that you can get groups running and get things rolling? I mean, in a just kind of a nuts and bolts fashion, do you?
Yeah, I'm not advertising, so I'm growing this very slowly. It all depends on the demand. And a few months ago, I was actually thinking about creating a second group, so it might happen. But right now, I just have one, which I have about 10 patients. At some point I had 12, but some patients moved, and so that's why I'm on hold right now. And so the demand primarily comes from the other centers that refer patients to there are 5 providers prescribing Suboxone Matrix right now. And so those patients get referred according to the geographic situation where it's more convenient for them, and if those doctors are accepting patients. So that's how it works. So in a sense, I'm not doing any kind of advertisement for this, but I often get referrals from sometimes pain clinic is a big one. So we have a very robust pain clinic, and when those patients we identify that those patients have a problem with abuse, those patients get referred to us.
Anyone else in terms of how do you plan for implementation? Do you wait till you have 10 people on your list and then you implement, or it sounds like when people call you've got to respond within 24 hours. So
Yeah, it's the dynamics of planning are a little trickier when it involves a group. especially get started because you need a certain number of people to have a group. If it's just a matter of a prescriber seeing a patient, there are various ways that practices have of setting up urgent visits, but that doesn't actually necessarily require a whole lot of advanced planning. Especially if, as Jessica advised, like, you start slow, like, you're not gonna have 12 patients on day one, it's just not going to happen. I would say at institutions where I've worked, we've gotten patients, some referred from other staff in the institution, and some sort of word of mouth, patient to patient, the kind of word is out, oh yeah, they're doing this now in Somerville, you know, you can call. And so it will, once you start doing it, it will grow, but it doesn't have to grow in a scary manner. And it really can be controlled. And again, one of the things to think about as you're starting is obviously this question, is there gonna be a group? Is there not gonna be a group? Do I wait and see to then do a group down the road? Obviously you need a space for a group if you're gonna do a group. But also how is the prescriber going to arrange their schedule in terms of a routine, of the urine and the prescriptions, and there's something to be said for cohorting the patients, say all in one half day. That's, you know, buprenorphine day for Dr. Grossman. But that said, there's you know, patients who may not be able to make that one half day, and you do want to meet them where they're at, and so you often may sprinkle them through your schedule. I actually do a bit of both, and I intentionally did that cohort thing at the beginning, partly to get the MAs used to there's a rhythm, and this isn't scary, and you know, patients come, if they're seeing Dr. Grossman on Monday morning, then you know, they're doing urine, and that's just that. Now that trainees with me, obviously, it certainly makes sense to have them cohorted, so then the trainees see them also, and then that's what the group is. But I also have them sprinkled through my schedule, and I figured out a system in the electronic medical record, so I communicate with the MA, so that they know ahead of time who's going to need urine, and it's fine.
What's a comfortable caseload? I mean, you've been doing it some of you have been doing it for quite a long time, others are newer than that. What's a comfortable number of patients to follow?
The Colleen LaBelle system, which is based on nursing, which means that for the nurses do about 80% of all the visits, right? So the nurse does the intake, I see them for the induction, and then they see the nurse 5 or 6 times before they come back to see me. And then once a monthly, I see them every quarter, and the rest of the time they're seeing the nurse, so that's how it works. So in our system, a typical nurse will have between 1,100 and 1,300 visits a year, right, which is massive if you compare it to regular primary care nursing, right? And so the recommendation for that when you have a mature program is to have about 100 to 125 patients per nurse, if you have a mature program. If you're starting out, you're probably going to be, you have a lot of people coming every week, you're probably going to want to stay around 60, 70, until you're about 20 or 30 per month, then you can go to 100, 125. And then you just adjust your spigot of primary prescribers depending on the nursing model, right? And like Ellie said, if she wanted to fill her schedule up with all patients taking Suboxone, she would probably take 500 patients. If she wants to maintain a mix, she
But
probably
then I'd be
takes.
violating the TDA regulation.
Right. What's the maximum now?
275.
275, right? But most people, it's really dependent on how much you want to do. We have primary care providers who are at the 250 mark. We don't let people go above that because we're not quite sure how the feds consider it when someone's on vacation, you're covering their patients.
Yeah.
Like sometimes the feds say, well, no, that counts against your, so we keep people less than 250 just so that you don't get in trouble. And I have people as low as 5 or 10, right? If you're integrating it within their panel, it really depends. The prescriber typically is not limiting reagent.
The prescribers can't, that first year, you're totally mandated to only do 30.
Yeah, so it is one thing to think about is it is not that, especially if you are covering for other providers and work in a larger or even medium-sized practice, hitting that number, what the feds have told us in the past is they count it as live prescriptions. So to have any 30 live prescriptions at any one time, can be an issue in that first year. So you have sort of things to think about in building your practice is keep an eye on your prescribers, and so that as soon as it's been 1 year since they've had their X number, they should fill out. It's a very short form, I must say, especially for the federal government. Is a very short form to up your capacity to 100, and that just adds a cushion.
To 100?
Yeah, and then after that, it can be 275 with, I can't remember what experience you have to.
Do you think they'll change that?
Probably, but I don't know. It took years to get to 275.
I mean, this is a funny thing, right? So Ellie and I, if we wanted, we could provide 1,000 patients with Percocet every day, and nobody would come investigate, right? Like, but because we do prescribe buprenorphine, which I've been personally visited 7 times by the DEA spec team, right? It's sort of a weird phenomenon, right? That you're actually doing something to help the problem, but for some reason you feel like you're doing something dirty because they're visiting you. It's sort of a weird, it's a weird phenomenon. So I hope they get away from that. I hope they change the legislation on that at some point.
See, just for the sake of the audience, because everybody may have different understanding, can you distinguish, for example, methadone treatment from primary care treatment?
Sure. So, federal guidelines in the 1970s established that methadone had to be in its own OTP, opioid treatment program. And so these are it's very siloed medical care basically that requires a lot more intensive observation, which is very helpful for some people. But so, you get dosed every day with liquid methadone, you're observed by a nurse. There are counseling requirements, there's random urine drug screening, there's all these, requirements that you need to meet. And so if you're a patient that needs that kind of support, you're seen every single day and you're evaluated and your dose is held. If you're not doing well, things are adjusted on a day-to-day basis that you can't do in primary care. And you can slowly graduate to take homes, but you're kind of stuck there, right? So it can be very limiting for stable patients. And I have some patients who have been on methadone for 5-10 years, and they don't really have that option to have a little more flexibility, unlike buprenorphine. There's limited access to methadone, and they haven't really expanded the OTPs. So unless you're in an area where your patients can access it, it can be hard to get to. And there's actually very good evidence since the 60s that it's a really effective treatment. So there's a lot of stigma. People don't believe in methadone. A lot of people are seeing the people on methadone who aren't doing well, because the ones who are on methadone and who are doing well, you would never know, right? It's like their blood pressure medicine, they're living lives, they're having kids and families and jobs. So I think there's an important role for methadone, and it definitely is a higher level of care, but one that it exists with buprenorphine.
And it doesn't help when it's called methadone mild too, with the stigma. So the difference then, so by offering primary care based treatment for addiction, we expand access, make it more feasible for people. But there must be some difference, right? There must be some distinction between the type of patient that you can treat in primary care and the person who needs more structured therapy. So I think it might be helpful to really characterize who's an ideal patient or a right patient for primary care based treatment.
So I think there are so we have 3 treatments for opioid use disorder, right? We have methadone, which is a full agonist, buprenorphine, which is a partial agonist, and then we have naltrexone or Vivitrol, which is the blocker. And the second 2 can be done in any primary care setting. Figuring out who would benefit, I think there are 4 things. Number 1, it's whether what your patient has experienced before, right? So that's really going by what they've tried. Have they been in a program before? Have they done well in methadone? Do they not like the taste of buprenorphine? Do they need that? Patient preference is a really huge part of this treatment. The second is access, like I told you. So where are those clinics, and can they get to them? What their overdose risk is, right? So methadone and buprenorphine have much better evidence for people who are are very high risk for overdose than Vivitrol. But either one of them are very, potentially reasonable options. I think those are some of the big pieces.
The only thing I want to add is that the best numbers from the CDC is that we add a couple 100,000 users who are dependent on opioid every year. And so we only have about 1.5 million treatment spots. There's a demand for about 3 million to 4 million every year. So just in Massachusetts last year, and this is where Massachusetts is amazing about collecting this data, but in Massachusetts last year, for all substance use disorder combined, 28,000 people showed up somewhere and said, I need help. And the medical system said, sorry, no room at the end. Right? Like this is, and for substance use, for just opioid, it's probably around 12 or 14,000 people actually showed up somewhere, an office, in an ER, in a hospital, on a cardiac unit, saying, I need help with this problem. And we said, if you needed a heart transplant, we could do that. If you needed a catheterization, we could do that. If you needed brain surgery, we could do that. But you need an easy prescription of buprenorphine or Vivitrol or methadone, we can't do that. So the access issue is a huge issue. This is why there's this big push, right, for everybody that prescribes, this big push for more people because the need is out there. Like there's no quibbling about it, and it never ceases to amaze me that we're willing to accept this state of affairs. We're just willing to accept that. Right? We made the system so beautiful. Anywhere in the state of Massachusetts, if you have a heart attack, you can get a cath within 2 hours, no matter where you are. Like you get a helicopter, you get, right? But in something that seems so simple, like Ellie said, this is really not even the most complicated things we do in a primary care office. Right? Like putting in a Nexplanon on is more complicated than prescribing buprenorphine. So the access issue is really a crucial problem for us in healthcare. I really think of it. I personally think of it in terms of civil rights language. Right? This is our issue. This is our generation's issue in healthcare to figure out. It's going to be intolerable in terms of being looked at by history if we can't figure this out.
Yeah, to that point, that was really well said. Thank you, and that's part of what we're trying to push by pushing integration, and we appreciate people like you know more about this, speaking about it. Can you talk more about how you talk to your peers? I know, Dr. Grossman, you said any MD who doesn't see the need is not living in reality, but we know that a lot of your peers, not at your clinic, but your peers in terms of those who have those letters after their name, do have their heads in their sand. So any of you, any of the four of you, if you have thoughts on how you speak to them, if you do choose to engage with them, or Jaime, you said sometimes it's better just to not think about that some people don't accept it, but that would be helpful for those in the room to hear. And maybe those watching if they're more hesitant, because even well-intentioned doctors are hesitant.
Yeah, this is one of those things is, you're hesitant to offer service because what if you get patients who you don't like or you don't want that type, and word might get out and word might spread. Okay, well, wait and see if that problem happens, because for better or worse in Massachusetts, although yes, there is the need, there also are a lot, relative to a lot of other geographies, a lot of treatment options. So it's not, so yes, I opened, put up a shingle at Somerville Hospital Primary Care 2 years ago. Like, the waiting room wasn't flooded the next day. The demand, you can control the demand and control access in a way that your practice is comfortable with. The way I would think about it, the way I try to frame it to trainees is, there's a lot of skills we have as healthcare professionals that we're glad we have. We may not need it today, we may not need it tomorrow, but if a patient walks through my door on Thursday and needs it, I'm really glad I have it. And so, doing even getting over that threshold of doing the training, getting the X number, because again, just the experience of doing the training gets you a bit more familiarity with the subject matter. there is a huge step off in terms of number of people who have the training and have done the waiver and then actually prescribe. So clearly that doesn't fix it all, but it is a step. And then no one's gonna wanna do this alone. So there has to be at least 2 prescribers and some supportive staff. So again, how do you actually make it happen? No one person can do it. And it's a bit of both top down and bottom up, because otherwise it's not gonna fly.
Can you talk a little bit about mentoring? Because I think that one of the challenges is, as physicians doing something new, is we still are apprentices and we still feel like we need to learn from somebody who's done it first. And I think there are some mentoring models out there. Can you talk a little bit more about what it is in real life? If you do your 8 hours of training, then what?
First, I would go back to your question, which I thought was a powerful one. I think that sharing stories is a great way to connect with people. And one I like to talk about is a colleague who was not interested in treating at all, right, furthest from it, but was forced to get the waiver. And that was it, right? Got the waiver. And lo and behold, some months later, one of her longtime patients opened up about the fact that they had a use disorder and they were, abusing heroin. And she was able to treat that person, right? Nobody else. She didn't open her practice, but she was able to give medicine to that person to save them. And that made her a believer. And she didn't open her practice. She's not kind of advertising, but to be able to do that for your patients and be ready at that moment, I think was really life changing for her in a way that she hadn't experienced in primary care. I think sharing those moments with people who are hesitant is important. In terms of support, so you do your 8 hour training. You're in 4 hours online and 4 hours in person, or 8 hours.
24.
Or 24 if you're an NP or a PA, right? And then you can you're welcome to call us. So there's a great network of OBAC depending on where you are. Most people are very happy to be supportive, but there's also some formal supports online. So there's PCSSO, what it stands for.
Prescriber Clinical Support System.
So this is an entire online course that's very digestible, put out both for prescribing opioids and for addiction treatment. It is really fantastic and well done. That offers a lot of great support. There are webinars. They're constantly updating their materials. So I've used that a lot, and I think that's a good resource. Your local, academic medical centers are more than happy to help, and so those can be very, very helpful. Showing up and, I remember as a resident, I called Colleen. No idea who she was, and she just gave me guidance, right? So use those. Your labs are, our toxicologists are experts, so there's a lot of good resources. I wouldn't hesitate to ask for them. And there's echo models now in many different health systems, which telemedicine, allows weekly, monthly, bi-monthly at BMC, but I know there's other places where people are presenting their cases, and it's a lot of health centers getting together and really feeling supported and able to digest it and ask questions and bring questions in real time. So I think those are some good resources that are out there.
So would it be possible for somebody to look up the Addiction Medicine Center at BMC and get names and numbers, or?
Yeah, they actually have a great website.
Yes.
I actually have a question for each of the panelists. Most of you talked about fairly intensive in the beginning visits, shared medical appointments, and I'm just wondering how often you're encountering issues with patients who have all of a sudden issues with co-pays and deductibles between the visits, the medication, and how often is that sort of entering into as a barrier potentially?
Yeah, I do have one thing that I've experienced in the very beginning as few health insurance, they require prior authorization. I think Medicare is one of them, believe it or not. So, if I'm gonna prescribe Suboxone or buprenorphine for the first time for a patient, I have to go through a process to get a PA from Medicare, which is absurd. But I think that, in the state, I think the governor, lately, there was an issue for most of the issues, I don't know,
Yeah,
the experience, right? So that's one issue that we have as far as for Medicare. So there is a problem with copay because the medication can be expensive, and so it is an issue that we have to navigate the system. Sometimes in my setting, I have a couple of patients that they actually do not pay anything for the medication, which it is absorbed by the clinic, pay for that. That's what usually happens. As far as for your question, because I think it's important, there's nothing more powerful than having a colleague knock on your door and say, I need your help for this patient, it happens, like it is just a matter of time. And, I have two colleagues that have already knocked on the door and I was there and that patient is being treated. So it is really powerful to see because, like Yemi said, there's nothing more rewarding to provide treatment for those patients. And you can see, those PCPs are seeing the change in front of their eyes, how those patients are behaving. That's really powerful.
So at BMC, we have a heavy Medicaid mix, so most everything is paid for. I do have a handful of patients, one in particular who has a different kind of insurance and is, requires a different buprenorphine than the typical Suboxone that's covered. And there are some big hoops that they go through every 6 months to re-up the authorization. So in terms of that, there is sometimes, heavy paperwork at the beginning, but a lot of that is being worked through at the state level. So that, in terms of co-pays, I don't feel that same struggle just because of my patient mix, but I can see that it would be tough.
So yes, it's an issue. It's hard to get around the visit copay cost. But there are times where for a patient who has been stable in treatment who now has an insurance lapse, that I might say, yes, I can write a script now without a visit, we'll talk on the phone, or those are just the things we do for other chronic diseases as well. And then there are, in general, with my prescriptions, I write the prescription to match the visit interval. So initially they're 1 week scripts, and they're 2 week scripts, etc. There are some patients who have expressed to me that, that a weekly copay for their medication prescription is a burden. In which case, I'll have a discussion like, okay, you're still gonna see me weekly, we're gonna do a trial of, I'll do your prescriptions 30 days, and we'll see how this goes. So there are things you can fudge, there are some things that are more challenging.
Yeah, it can be, which I think for Jessica and I it's a little bit easier because when you have a heavy Medicaid population and you're operating in a system that's used to dealing with people who are somewhat dispossessed, we're set up to take care of people with no money, right? And in addition, in a fee-for-service model, the average Medicaid patient visits 3 times a year, right? That's the average. The average patient on buprenorphine visits 14 times a year. So the amount of revenue you're generating for you more than justifies your ability to be able to pay for their prescriptions every now and then with an insurance life. We do the same thing that Evie's talking about. If you come every week, but you have a copay, we just say that, it's 1 visit over 4 visits, right? So you just pay 1 copay. And our pharmacy will do that. They'll just take the copay for the month, and then they just dispense it every week without charging the copay. So there's arrangements you can do with that, but it can become financially for people with private insurance. So ironically, at Lynn, our patients that seek addiction care actually are patients with the highest rate of private insurance, right? Because they can't get care anywhere else, so they end up coming to the health center. and it can be an issue, but we work with patients. We never, I mean, I think some of the most heartbreaking stories that we hear is people who are they're sort of forced to leave their place where they're getting care because their insurance is no longer accepted. And then they relapse because they can't find a place to climb. That's sort of just heartbreaking. So we never allow that to happen. But we're set up for it. We're a community health center. We're sort of set up for it. So it would be this would be an area of I think of struggle for private practices. It's something that would have to be explored sort of more in depth.
One thing that I usually do is invariably actually patients are saving money because it's so expensive to buy drugs on the street that eventually they say, oh my God, now I'm saving so much money, you know, I have money to do my stuff. So the problem usually is actually the very beginning when those patients need to come more often and then they have to pay a copayment. And I usually explain to them, you know, this is the game. You know, we have to get you stable. You have to come over here on a weekly basis, and you have to do this copayment. It's the price you have to pay. But you know, if there are struggles, we work with the patient. You know, this is something case by case. But eventually, when they are stable, they are actually saving a lot of money.
Jessica, earlier you mentioned screening patients. Can you guys break that down a bit more and talk about how you screen your patients to identify if they do have a substance use disorder?
So there's DSM-5 criteria out now for substance use disorder. You need to meet, there's no longer substance abuse and use disorder. It's really this continuum of mild, moderate, and severe substance use disorder. And so, you know, you can find that criteria anywhere, and it's really kind of seeing how the substance has affected their life, right? And if it's affected relationships, jobs, with the law, you know, with their health, and you know, if it's affecting all these areas and they're still continuing to use, then by definition they meet criteria for use disorder. And in the disorder is also tolerance and withdrawal, which are not part of the use disorder, but you know, part of the disease. And so that can be very obvious for many patients, and I think that where it's helpful to have maybe a second set of eyes would be for your patients on chronic opiates, for chronic pain, who we know that a certain percentage of them are going to develop use disorder. And so I think those are the more tricky cases where it's helpful to have a second, either an addiction consult or some other evaluation sometimes to tease out what are the hoops that we make people go through for their chronic narcotic pain medicines, and what is lack of control.
Yeah. I don't. So maybe you're asking from some primary care perspective, how do you find these patients?
Validated.
A ton of that.
Oh.
About the validated questionnaires.
Yeah, yes. So there are many. Online, there are many validated tools for screening, the initial screen for substance use, and then for assessing, you know, for going to that. So, I like the 2-question screen. You know, for primary care, I think it's a nice one. You know, in the last year, have you used any illegal drugs? In the last year, have you used drank more than for men 4 alcoholic drinks, or for women 3 in a setting, and then you're able to dive deeper.
So these are 2 questions, and they're so common that for us we use Epic, and it's already built into Epic. You just train your medical assistants to ask the question, and we build it as part of the rooming sequence. So they ask you can decide how aggressive you want to be. We're once every 6 months. We can do it every visit, which is a recommendation, but there's so many screenings you're supposed to be doing. But the 2 questions are very straightforward, very easy, and like any other screening questions, people can opt to not tell the truth, but they know you care because you're asking, right? So maybe next time they'll say yes. So like domestic violence, right? Yeah, we know from the research of domestic violence, you have to ask several times. You don't just sort of ask once and forget about it. So, but there are lots of validated questionnaires that are very short, not time-consuming, well-researched.
And then there's, we didn't really talk about adolescents, but that's a whole other area that to intervene in prevention as well. And so there's SBIRT, the screening, brief intervention, referral treatment, which is kind of it's a big model for how we recommend people screen and engage in treatment. And then there's S2BI, which is another expert model for adolescents. And so the American Academy of Pediatrics put out like a teen-centric questionnaire for geared to them. So a lot of good resources.
And if I should actually pick up on the adolescent and pediatric side of the equation, we have an interesting question from one of our viewers on the live stream, indicating that some studies show that an awful high percentage of adults with SUD began using prior to age 18, and so this person is wondering, sort of, can you say a little bit about what role you feel pediatric primary care can play in responding to the opioid use epidemic, knowing that many users are starting under the age of 18.
So first my family had, and then my addiction had. It's a great question. And so we do know that, substance use has a really strong genetic component, and we know that the brain is still developing until your early 20s. So any drug exposure, tobacco, marijuana, alcohol, and in those developing years, just increases your risk of substance use disorder. So what does that mean in primary care, in pediatrics, and family medicine? It means that I'm talking to my teens, I'm talking to my parents about that, and about, especially if you have a family history, like, I'm telling my patients in methadone, if you have kids, delay, like, have this conversation. And it's not just experimentation, right? At this point, like, you are at really high risk, I think 50% of getting a substance use disorder. So in that sense, there's a lot that pediatric providers can do for prevention. And then it's knowing that, you might meet them after they've already tried things, right? And where they fall in that spectrum. And so it's the harm reduction approach of meeting them where they are and trying to help them cut back, right? So I think those are two roles. And there are wonderful resources in Massachusetts for adolescents. So there's the Catalyst Clinic at Boston Medical Center. Their Children's has an ASAP program. And they have a lot of great resources and supports for adolescents.
Can you clarify the age when screening should begin?
Yeah, so I think we already use heads and all these other screening tools, but there's age-appropriate ways of discussing these things, and so it's just using developmentally appropriate questions at every age. So whether it's starting at 12, 10 to 12 is kind of the range where you start to have these more gentle conversations that are geared toward what people are seeing, what they know, and this is not flooding them with kind of information that's above their level.
And particularly for teenagers, where it links up is that we can't remember the numbers, but something like 50 to 60% of all mental illness is evident by age 13. So this means that really we should be having school-based medical care that's identifying behavioral health issues in middle school, right? Which is something you don't quite think about. But we really should be helping identifying people who are suffering from depression and bipolar disease. And parents don't really like thinking about that. As a society, we don't like thinking that we should be screening for depression in 6th grade, but people need it. We just have to sort of face the fact that people need it, and if we did a better job with mental health, we might do a better job with substance use disorder.
Any more questions?
There are a couple more, yeah. A couple of nuts and bolts issues. One question about whether any of the panelists have experience with patients diverting or giving away or selling their medication, how you might deal with that, and then also if you have experience with court-involved patients and how does that change the equation, if at all?
So diversion, so yes. I venture to guess that much of it I don't know about it. I don't know, but some I have uncovered. One can and should, and the DEA expects you to, do routine urine tests that include testing for buprenorphine. That said, it is entirely possible for a patient to sell or share 99% of the pills in their bottle and take one and pass that test, and I think they all know that. I'm not letting out some secret. so that's not a great test, but it's something. And then there obviously includes like the request for early refills. And I think many of us have a sort of patient-doctor understanding, contract agreement, whatever word you want to use, as people enter treatment. So sort of lay out the ground rules ahead of time. You tell me the truth, I'll tell you the truth. You treat me nicely, I'll treat you nicely, that kind of thing. And on there is, I expect that you will not sell, share, or misuse the medication prescribed to you. And clinically, I think many of us as healthcare professionals, we tend to want to help people. We tend to be forgiving. So many patients might get a stern talking to if something is uncovered, but it depends on the level of what gets uncovered. So it could be sorry, no more prescriptions. It might be more often that better not happen again, and I'm going to be seeing you weekly for a very, very, very long time. It could be there are regulations that allow OTPs, methadone programs, to dispense buprenorphine. There are not many of them doing that in Massachusetts yet. But again, for patients who say, I like the feel of buprenorphine, I don't want to be on methadone, but they have exhibited that they have a history of diversion, well, sorry, you're going to have to go to the methadone program to get your buprenorphine every day. There are various other sort of tech-based tools that are under research around, watching somebody do their at-home dosing and having a lockbox that dispenses one dose at a time. So, in the future, we may have other ways of trying to prevent diversion. It will always exist, and I will always be able to uncover only a small fraction of it.
I would also just note that a lot of diversion, you guys all know this, comes out of the lack of access problem. People share it because they care about their family and their friends, so, which is why we have a lot of diversion in jails, because it's not allowed. So it's not all profit-seeking, drug dealing bad.
Right.
I think that's probably no better, but I know I have one good paper that came out of Australia where they tracked what was happening to the diverted Suboxone, and about 70% of the diverted Suboxone was being sold to people who just wanted to become sober without using the healthcare system. So about 30% was being used to try to sort of have it achieve euphoric effect. One of the things that I unofficially track is the price of Suboxone on the street. Anytime where we've started a Suboxone program, the prices drop dramatically. One of my goals is there's so many Suboxone programs that essentially it's worthless. It'd be like buying amoxicillin on the street, which you can do, by the way. It's not like it's just Suboxone that gets diverted, right? All the medications. But I was just reading, I don't know if you guys read the Boston Globe this morning. They actually interviewed Dr. Wakeman from MGH and Dr. Ruth Cody from the Franklin County Hospital. But the FDA is looking at injectable Suboxone monthly right now. That would alleviate a lot of the concerns by people who regulate us about diversion. But I think I agree with Ellie that that's not we're not whatever we prescribe, we're not set up to be detectives and police officers, right? Where we do I have control by Dunkin' Donuts to see if my diabetic patients are going? I don't, right? It's just oh, you have hypertension, what are you doing at the bus stand? It's not really our role to go there.
Yeah, I used to be more concerned about that as well, and thinking about counting pills, and every so often I decided that this was not my role to do this, and I'm sure that there is some degree of diversion that happens. I'm not trying to control that. I can't. It's I don't know what happens day to day in people's lives. And hey, if a patient gets a Suboxone from someone else, eventually this patient can think about, looking for help somewhere else, because they finally try the medication and it's going to help them out. And it has happened. Because actually, the majority of the patients that I see, they have already tried something else on the street.
Yeah, there was another part of that question.
Court-involved patients and any experience with our court system.
So a lot, because as we mentioned, a lot of our patients are involved in the criminal justice system because of their addiction and their substance use disorder. So we see a lot of patients at BMC who are either post-incarceration, maybe on parole, they've been in and out of the court system. They're DCF involved as parents. So our nurses work closely with POs, with site permissions. And I think that culture has changed a lot, which is nice, even since I've been there, that, like we were talking about earlier, that's the judicial system is more accepting of medication as part of the treatment. And so I think it's a really big population that we're treating that's undertreated in jail, as we know, and who are at highest risk. So right when they come out, they are 56 times more likely to die in Massachusetts than anyone else because of that overdose risk. And so I work with these patients a lot. It's something that I have a lot of, I think the big advocacy piece that we need, I would just say. And I have to say that there are many of my wonderful patients, right? These, for the vast majority, people have been humbled by their disease. They've been humbled by this process. And I have met some really, really fine people who are doing great in their recovery and doing great in society. And so that's another place with a lot of stigma. But we can do a lot of good for them too. And I think they can be very good patients. So I wouldn't discount that relationship either.
Any questions in the room before we?
So this may be a good final wrap-up question. So I'm Katie, I'm Policy Director of Accountable Care here at the Health Policy Commission. This has been an awesome discussion, so thank you so much. In state government, we don't have a lot of opportunities to talk directly to people who are serving the patients. We think about policies to improve on a daily basis, so I really appreciate this opportunity. So my question is, we've talked a lot about federal waiver rules and things that the feds could change to improve access and make your jobs easier and make the lives of your patients easier. But any other recommendations about states? We've talked about co-payment and deductible forgiveness, and we've talked about the prior authorization forgiveness, things that sort of the state has already moved a little bit on. But other creative ideas that you guys have for us about how we could move things forward for you.
Can I add a second part to that, which is
Sure.
you mentioned that there's a cliff after people train, they do their 8 hours of training, but then they never prescribe. It seems like there's a gap between the knowledge you gain from doing the training to actually providing care, and I think that's where we need more information, more implementation wisdom. Do you have ideas about what it would take to get people from just doing the training to actually doing the treatment?
I think that's a tough question. As clinicians, we're not always aware of which regulation is stopping us from doing something. We don't know if it's going to be done in the state.
That's our job.
All we know is that it stops us from doing stuff, right? I would say that probably one thing would be to force the insurance companies to not have pre-auth for medication for which there is no substitute. It's not like you're submitting it and they're going to say, oh, why don't you use this medication, right? They're forcing you to do something knowing they're going to approve it, right? Because there's no other option. So that's it's a ridiculous state of affairs. You're asking for pre-approval for something that you're going to authorize. It's sort of strange. Second, I would say that even though we always complain on the primary care side that we're really poor, we get no reimbursement, behavioral health reimbursement is just pathetic. Like when Elliot was talking about the group therapy visit rate, I mean, we're talking like $35 or something. Like it is the group, the reimbursement for behavioral health is really, really low, and I think it plays part of it because a lot of people, like I said, need to start this without behavioral health, but their leadership won't let them hire behavioral health because behavioral health can be such a money sink, depending on how you set it up. And then 3, I think that there's been some movement in incarceration, but a lot of, I mean, at the federal level was just blocked, right? Federal level was just not allowing it. But there's a lot of state level prisons and jails that, and I was reading that there's like 3 or 4 that are already doing it now, but to help encourage the incarceration, to corrections to help treat that. And then to also, I know that there's some controversy around the drug courts in the judicial system. Like there's some controversy surrounding that, to make sure that the state and the policy is supporting the concept of drug courts. And of course, this is hard for sort of any politician to sort of hear, but the things that prevent drug use that we know of are anything that strengthens the family, right? And so we're talking, and that's why, right? We're talking about having sidewalks so people can walk to school with their kids. We're talking about figuring out whatever zoning policies allow poor communities to have supermarkets. We're talking about funding for summer programs for YMCA's and Big Brother, Big Sister programs, and like those are not sexy things, right? But anything that strengthens the family structure. For instance, if people could work one job and be a single parent as opposed to having to work 1.5 or 2 jobs. Those are all sort of policy level things that set the stage for us that I can think of. In terms of mentorship, the thing that's very interesting, the experience that I had in Lawrence, is that essentially Lawrence is 100 super hardcore bleeding heart liberals with about 20 super hardcore religious people who believe that they have to give back, right? So these are people who truly are dedicated to social justice. And we put in place a system where it's easy as it gets, right? The nurse takes care of everything. Essentially says, Dr. Grossman, sign here, please, right? That they take care of everything, they track everything, they do the drug screens, they call the patients who are in trouble, they do the kicking out of the patients if necessary, so you don't even have to dirty your hands, right? Like it's all taken care of for you. And even in that setting, once we train people, only about 20% of people ever actually voluntarily prescribe, right? Even in a setting where it was essentially as easy as you could possibly get, so built-in mentorship, built-in nursing support. So I think that in my mind, when I look at how many people get trained, that's what I think. I think, about 20% will actually become involved in this. So I think you just need to provide an incredible amount of support. And like the program that Jessica mentioned, they actually will provide you with, anywhere in the nation, with a mentor that you can call if you have a question. You just have to provide an incredible amount of mentorships to get about 20% of people to prescribe.
So do you think that there's an opportunity with realignment of payment, if this was a prioritized area of care, you could add it to risk contracts, ACO types of things, would physician behavior change?
Well, I think it's Katie. I think she doesn't have to worry. As soon as you have an ACO capitated model, there's going to be such pressure from leadership to adopt MATs. It's just going to be, not be able to resist that kind of pressure because the amount of money savings it represents is just enormous. I think Colleen actually wrote a paper on this, how much money the 14 health centers that you originally gave the grant to, how much money they ended up saving Medicaid. It was in the millions of dollars.
Yeah. But one pushback I will say, I think for the 3 of you, yes. Atrius they've been taking risks for years. And you guys have more established programs, right? So just to point out that the financial incentives have been there on the commercial side, but there's still something missing, right? There's still some reason why you can't, hang your shingle in the way that Ellie has, is that everyone come, right? It's not, it's not quite there yet. And so that's the kinds of things that I think about a lot, that obviously it's there for poor people, it's there for Medicaid, it's, those are the systems that are best equipped to do that, but how do we help the rest of the system be better equipped to do it as well? And I think financial pay reform and ACOs and things will start to get us there, but it's not gonna do the whole job.
Yeah, the beginning to get us there. It's also changing the culture in medicine. Like, I can't be telling my trainees, sorry, addiction, like, you go, Tuesday 11 in the morning somewhere else for that. We don't do that here. And that's a culture change. And that happens with time. And, should we say as a state, like, if you are a training program in psychiatry or family practice or OB or peds or internal medicine, that all of your graduates have to get their X number at the time of graduation?
Yes.
That may not fit. But again, because once this is just kind of bread and butter medicine, we'll have fewer of these conversations.
And then there was a piece the other day about a resident intern in one of the big hospitals over here, and he wrote in the New York Times. I don't know if you heard about this, but he was getting pushed back from the medical director and from the residency director, saying that we do not want to attract those patients to the hospital. So it is this cultural piece that is hard to overcome, and I think that to have those, to probably find physician champions in some of those private settings where you can actually mentor those physicians, that's probably a good idea because it eventually spreads. But you have to have those physician champions that can carry on and start to show people this is just a regular disease that actually shows a lot of people, and that is our responsibility to take care of this population.
To put a face to the patients too. I think that really compels physicians when they have their own personal experience, like you mentioned with your colleague and mine, and that's why I thought it was really important for us to share our own personal stories with a specific patient that changed our practice. So we're at the top of 2 hours, and I thought this was excellent, so thank you so much to the panel for I think that the summary points were don't go it alone. There's mentoring and support out there. The need is very deep and urgent. This practice adds tremendous satisfaction to everybody involved, and it's essential to do the work to get the buy-in from staff and leadership as you embark on programming. So thank you all for coming, and enjoy the rest of your day. Thank you so much. And thank you to the Health Policy Commission for hosting.
Everyone? Excuse me. Before everyone leaves, I would really appreciate if there's some evaluations just to give feedback on the event. So if you're from the HPC, you don't have to fill it out, but if you're a visitor, we'd really appreciate it, and it would help us plan future events like this. So I'll pass those around. Yes, can you just grab that bigger I remember that. I